We present the case of a 58-year-old male with no significant past medical history presented to the urology clinics with low tract urinary symptoms. Physical examination was unremarkable and laboratory tests, including renal function, were within normal limits. Ultrasound was performed finding a 5 cm heterogeneous mass located in the anterior/midline aspect of the left kidney extending toward the renal pelvis. After this finding, a contrast-enhanced CT scan of the thorax, abdomen, and pelvis was requested, revealing a 5 cm anterior midline mass in the left kidney with suspicion of invasion of the renal pelvis. No enlarged lymph nodes or distant metastases were observed. The tumor demonstrated heterogeneous enhancement, suggesting a renal cell carcinoma. The contralateral kidney and other abdominal organs appeared normal. The patient was scheduled for a laparoscopic partial nephrectomy. From the patient's medical images, a three-dimensional model of the kidney is generated, providing a detailed view of the tumor's relationship to surrounding structures. This 3D model allows for more accurate and safer preoperative planning and helps to anticipate surgical risks. The patient was positioned in right lateral decubitus. Pneumoperitoneum was established at 12 mm of mercury and 4 ports are placed. The left colon was mobilized medially, exposing the gorotus fascia. The psoas muscle is identified, and the ureteral and gonadal vein are dissected cranially. The renal hilum was identified, and the renal artery was isolated for clamping. The tumor was dissected using the 3D model guidance and the resection plane is marked. A bulldog clamp was placed on the select renal artery thanks to the 3D model to minimize ischemia time. The tumor was excised with careful identification and preservation of the collecting system were performed, and hemostasis was secured. Renorrhaphy was performed using a sliding clip technique with absorbable sutures. Fibrin sealant was applied over the closure, and perirenal fat was placed to reinforce hemostasis. The renal artery clamp was removed, and good perfusion was observed. The tumor was retrieved using an endobag. The ports were closed in layers, and the patient was extubated without complications. Total operative time was 75 minutes, with a warm ischemia time of 15 minutes. Estimated blood loss was 120 millimeters, with no intraoperative complications. The patient had an uneventful recovery and was discharged on postoperative day 2. Pathology confirmed clear cell RCC, Furman grade 2.1b, with negative margins. Serum creatinine remained stable, and at the 3-month follow-up, renal function was normal with no signs of recurrence.